Greetings from Kasturba Medical College, Manipal, Manipal Academy of Higher Education, India. Myself, Dr. Kavita Saravo, Professor and Head, Department of Infectious Diseases, and the organizing chairperson of this conference, have the pleasure to welcome you all. We welcome you to the fifth and the final day of the conference on combating antimicrobial resistance. This conference is being organized in observance of World Antimicrobial Awareness Day, which is observed every year from November 18 to 24th. As a part of this, we have a quiz program on antimicrobial resistance. Today's program is brought to you by Department of Infectious Diseases, Kasturba Medical College, Manipal, and Department of Emergency Medicine, Kasturba Medical College, Manipal. We have Dr. Nitin Gupta from Department of Infectious Diseases, Assistant Professor, and Dr. Prithvi Shri from Department of Emergency Medicine, who will be the who are organizing the quiz. I hand over the mic to them. Over to you, Nitin and Prithvi.
Thank you, ma'am. We are going to be your quiz masters for today, and we welcome you to the grand finale of World Antimicrobial Awareness Week quiz. So for the grand finale of the quiz, before selecting the finalist, we had conducted a preliminary round on November 14th of this month. And we had participants, more than 60 participants from all across the country who participated in the preliminary round from across various departments, including infectious diseases, medicine, orthopedics, emergency medicine, and microbiology. Out of all these, we have selected 5 finalists. They are from different parts of the country and they beat the others and have reached the grand finale. I welcome the 5 finalists. Dr. Manish Kumar from Government Dhruv Medical College, Dehradun, Uttarakhand. Dr. Ankit Mittal from All India Institute of Medical Sciences, New Delhi. Dr. Rahul Garg from Institute of Liver and Biliary Sciences, New Delhi. Dr. Siddharth Sadnani from Kasturba Medical College, Manipal. Dr. Rohit Gupta from ESIH, Rohini, Delhi. We welcome you to the grand finale. So let's move on to the quiz finale. So today we have for you 4 rounds. In that, the first round is the icebreaker. So here, each person gets one set of questions, which has 5 phrases or words. Now, these phrases or words are something which is related to antimicrobial use, consumption, some phrases we use day to day during our talk about antimicrobials, or it could be about antimicrobial program. Now, in these phrases, the vowels are removed, but they are given in the same order and spaces have been rearranged. Example, can one of you try and identify this word? The phrase rather.
Necrotizing fasciitis, skin and soft tissue infection.
So we have only removed the vowels. So in necrotizing fasciitis, there would have been an N followed by a C, right? So it's in the same order. Only the spaces have been rearranged. So this is actually infectious diseases. So the I, E initially have been removed and IOU has been removed. So, but it's in the same order. So D is there, I is removed, S is there, E is removed, S is there, E is removed. So the spaces have been rearranged, but it's in the same order and vowels are removed. Is that clear? Right, so it's like an icebreaker round. So each right answer carries 2 marks. There is 1 minute. So we'll have a slide for you with the 5 phrases or words and you have 1 minute to answer. Right? So each correct answer gets you 2 points. That's kind of an icebreaker. So shall we start? If there is no further questions, we'll start.
Okay, so the order is Ankit, Manish, Rahul, Siddharth, and Rohit. So the first question is for Ankit. On the top of the slide, you will see a timer. So basically, it's a 1 minute timer. Try to identify as many words as possible. No need to follow an order. Just whatever comes to your mind. Okay, so we'll start. Ankit.
Just one question, like I can use a pen and paper, right, with me?
Yeah.
Sure, sure.
No problem.
And the timer is in the form of a bar. So as the bar decreases, slice out rather, your time is getting over.
Okay. Ankit, you ready?
Yeah.
Okay. Others can keep your mic off, muted as of now. Let's start.
So the first one is antimicrobial stewardship.
Correct.
Uh,
It can be in any order, your answers.
okay. Fourth one is Clostridium difficile.
Correct.
Fifth one is New Delhi beta lactamases.
Correct.
Classification. The second one is some classification.
Correct. Which one?
AWR, I don't know, means it is some.
Yeah, you're close. Okay, time's up.
Yeah.
Sorry, Ankit will not be able to give that one. It's aware classification. This is how WHO classifies the drugs for. And the third one is pre-authorization. So you had 3 right, you scored 6 points. Next is for Manish. Manish, you ready?
Yes.
The last one is Kirby board diffusion.
Correct.
The third one is pharmacokinetics and pharmacodynamics.
Correct.
Manisha, time's up. You scored 2 corrects. You get 4 points.
The first one was the Go Blue campaign, which today being the November 24th, we are celebrating. Second is IV to oral conversion. The other one was Acinetobacter baumannii.
Okay, so the next question is for Rahul. Rahul, you ready?
Yes, sir.
Time starts now.
Fourth one is diagnostic stewardship.
Correct. Fifth one, yes.
Fifth one, yes.
Sorry, fifth one, yeah. Second one is something secondary. Third one is Pseudomonas aeruginosa.
Correct.
Fourth one is clinic. Second one is secondary something UTI infection, urinary tract infection, or secondary bacterium.
You are
Correct.
close, Rahul. Try to phrase it.
Your
time's up. You scored 2 corrects, 4 points. These are the answers.
Infection control, catheter-associated urinary tract infection, Pseudomonas aeruginosa, which you got right, Clinical and Laboratory Standards Institute, and Diagnostic Stewardship, which again you got right.
Next is Siddharth. Siddharth, you ready?
Yes, sir.
Okay. Your time starts.
So second one is antimicrobial management,
No.
No.
antimicrobial treatment,
No.
antimicrobial.
You can go for others if.
Yeah.
You're right with antimicrobial. The third might be a longer word. So try with something else.
Yes.
It can be related to the
Spreading
program.
awareness regarding antimicrobial. I don't know, what's this first one?
You're close, Siddharth.
Yes, sir. Spreading awareness regarding antimicrobial resistance, and I don't know. Then antimicrobial. Don't think I got it.
So close for both.
Just one guess, Siddharth, if you want to take with the second one again. Antimicrobial.
Management.
Okay, so it's okay, Siddharth. We have like more rounds, but
Yes,
you
sir.
scored 0 in this. So this was antimicrobial timeout.
Yes, and the first one was the theme of this year for World Antimicrobial Awareness Week, right? Spread awareness, stop resistance. Second, antimicrobial timeout, point of care testing, days of therapy, facility-specific clinical protocols. These were the 5 words.
Next is Rohit. Rohit, you ready?
Yes.
Your time starts.
Fifth one is Klebsiella. Klebsiella
Correct. Klebsiella?
pneumoniae.
Correct.
Perspective. Third one is no. Like
Yes, it's perspective. Rohit, just
fifth one
take
is hello.
Yeah.
We can hear you.
Daily defined dose.
Yeah,
Fourth,
Correct. Correct.
fine. Next.
perspective connectivity. Perspective. Third one is perspective.
Your time's up, Rohit. You have scored 4 points. There were 2 corrects. Just that there is some issue with your connection, mic. There is a lot of echo. If you have multiple devices, I think log out of one or something. These are your answers. It was prospective audit and feedback.
The first one was ventilator-associated pneumonia. Second is shorter is better. Prospective audit and feedback. Daily defined dosage and Klebsiella pneumonia, which you got right. Okay, so at the end of first round, we have Dr. Ankit at 6 points. At 4 points, we have Dr. Manish, Dr. Rahul, and Dr. Rohit. And we'll move on to the second round.
Okay.
This was just an icebreaker round, so we have like lots of interesting rounds coming.
Yeah. So we have, from now we have 3 rounds. First is the clinical vignette. Second is you have to identify the antimicrobial. I'll explain the second round later. And third is the rapid fire, for which we'll use the Kahoot app. Okay. So for clinical vignettes, so this will go in the same order. Each person will have a total of 2 questions. There are no passing allowed here. You will have 30 seconds to answer the question after the options are shown. And there is no passing here. Right answer will fetch you 10 marks. There are no negatives. Just keep in mind that these are close to real case scenarios that you see routinely, nothing out of the ordinary. That is one. Second is, most of the cases are what, I've seen somewhere or the other here in India. Because these are clinical vignettes, there can be a little bit of bias in answering. So you will have to remember one key rule, that Quizmaster decision is final, right? So we'll start with the first question. So Ankit, you get the first question. You ready?
Yeah, okay.
Okay, so this is a 52-year-old man, urinary tract symptoms, fever and systemic symptoms, empirically started on meropenem, after which there was improvement in 48 hours. Urine culture results shows E. coli, which is sensitive to piperacillin, tazobactam, meropenem, nitrofurantoin, fosfomycin, but it is resistant to aminoglycosides and fluoroquinolones, right? So we'll move on to the question. So what oral therapy will you advise for de-escalation?
Can you please show me the sensitivity report once?
Okay. So, Ankit, so for everybody, when we move on to the questions, the timer starts. So then we'll not be able to move back. So for the first question, I'm making an exception. So the sensitivity report is that it is sensitive to piptaz, meropenem, nitrofurantoin, fosfomycin, but it is resistant to aminoglycosides and fluoroquinolones. Should I move to the options?
Yeah.
Okay. So what oral therapy will you advise for de-escalation? I am starting the timer.
So, nitrofurantoin for 7 days.
Okay. So the answer is incorrect because this is a febrile UTI. Febrile UTI means upper UTI, pyelonephritis. Nitrofurantoin does not have good activity in upper UTI. So ferropenem is definitely not the answer. There's a whole lot of reasons why. So the question was, this was resistant to ciprofloxacin. So ciprofloxacin would not be the answer. So the option that we had to choose was between fosfomycin single dose and fosfomycin 10 days. So single dose is good for cystitis, but for upper UTI, recent evidence suggests that possibly 10 days would be a better option for de-escalation. This is a recent paper in CID where they compared fosfomycin versus ciprofloxacin as an oral step-down treatment for febrile UTI. Exactly what the question was. And here, fosfomycin was non-inferior. Therefore, the answer was fosfomycin. We'll move to the second question.
Yes,
Second is Manish. Manish, you're ready?
Yes, sir.
Yeah.
Video. You want their videos?
it's there.
Okay. So this is a 60-year-old man, 1 week of fever, malaise, and generalized weakness. There's a new mitral area murmur. Echocardiogram shows a small vegetation on the mitral valve. This is the blood culture report. You see Streptococcus mitis with sensitivity pattern as shown below. Whenever you're ready, Manish, I'll show you the options.
Yes, sir.
Should I show you the options?
Yes, sir.
Okay. So what is the recommended therapy? Your time starts now.
Vancomycin plus gentamicin.
Okay. So if you see the question, this is sorry, a wrong answer. If you see the question, here ampicillin is sensitive, there is relative penicillin resistance. So if you see the guidelines, European Society of Cardiology guidelines or BSAC guidelines, when the penicillin is relatively resistant, you have to ideally try and combine one beta-lactam and one aminoglycoside. So the correct answer would have been ampicillin plus gentamicin. We'll move on to the third person. Third is Rahul. Rahul, you're ready?
Yes, sir.
Okay. So you have a 45-year-old diabetic male. He has severe pain and redness over the right arm. He has fever. There is no history of animal bite or exposure to water. On examination, you can see that the patient has tachycardia and a little bit of hypertension. Blood culture is going Streptococcus dysgalacti, and this is the sensitivity pattern. Is the sensitivity pattern visible?
Yes, sir.
Yes. So when you're ready, we'll show you the options.
Just a minute, sir. Yes, sir.
You're ready? Okay.
Yes.
So what antibiotic will you prescribe?
Just can you go back, sir, once?
The timer.
It's okay. Go back.
No, the timer will not be able to readjust. After the first round, I am not going to go back. For everybody, after the first round, I'm not going to go back. So if you have to note something down, please note it down. I'll give you enough time.
Yes, sir. Yes. Yes, sir.
What antibiotic will you prescribe?
Sir, ampicillin plus clindamycin.
Okay, so this is not the right answer. So the thing is that For group A streptococcus, there is enough evidence that if you have a patient with complicated soft tissue infection, necrotizing fasciitis or a toxic shock syndrome, in that patient, you will have to combine with an antitoxin inhibitor, antitoxin or a toxin inhibitor. So usually clindamycin is combined in such cases. In fact, there is recent evidence that even in those patients where there is just a skin and soft tissue infection, but there is no necrotizing fasciitis or toxic shock syndrome, addition of clindamycin might be of help. But for non-A, non-B beta hemolytic streptococcus, there is a recent Lancet infectious disease paper that says that addition of an adjunctive clindamycin is not helpful. In fact, it may be counterproductive. So the answer in this case was ampicillin. Okay. Next is Siddharth. Siddharth, you ready?
Yes.
Okay. So this is a 60-year-old patient. He has AML. He was given induction consolidation therapy, day 6 post chemotherapy. He had fever. At that point of time, he had a BP of 94/78. His total leukocyte count was 500 and neutrophil was 40%. Blood cultures were sent and the patient was started empirically on meropenem, amikacin, vancomycin. He showed improvement, but the blood culture turned out to be sterile. No clinically identifiable source was identified. And the patient was, after initiation of antibiotics, became afebrile. Now the patient is afebrile for 2 days, and the current ANC count has improved from 400 to 700. So that you've seen the question. Should I move to?
Yes, sir, I've seen the question, sir. I can go to the options.
So, how long you give antibiotics? Your options are here. Time has started.
The ANC is right now 700. So can I see the question? Is he febrile anymore or no? He's asymptomatic right now.
He is afebrile and current ANC is 700.
700. Okay.
Your time is going to be up.
Yes. Yes. Sir. So the patient, so this stop if remains, like we can stop immediately, sir.
Your final answer is A?
Yes, sir. A, sir.
Okay, so this is the correct answer. So basically, this is a screenshot from IDSA. So in patients who have an unidentified source, they become afebrile and their ANC is on a rising trend and it is more than 500. There you can stop your antibiotics immediately. Okay, next is Rohit. You ready?
Sir.
Okay, so this is a question. 35-year-old diabetic male, Hodgkin's lymphoma post-chemotherapy, presents with persisting fever, not responding to meropenem and polymyxin B. There is right-sided external ophthalmoplegia. The patient was treated with amphotericin B for 4 weeks. He was improving and is planned for de-escalation. Take a look at the imaging properly, see where all, which all structures are involved, and then we'll move on to the next question.
Okay, sir.
So your time starts now. Antifungal of choice.
So we can go for tablet voriconazole.
Okay, so this is the wrong answer. So this patient is a patient of mucormycosis. Okay.
Yes.
And you can see there is intracerebral involvement. Patient responded to amphotericin B. So now you had 2 options that we can use for de-escalation. One is posaconazole and isavuconazole. For posaconazole, the suspension form has some PKPD issues. So extended release tablet is what is recommended. But this patient has CNS involvement. So now this is not in guidelines, but subtly, if you have to choose between isavuconazole and posaconazole in this situation, you would want to choose an antifungal which has a better CNS penetration. So between posa and isavuconazole, isavuconazole has better brain penetration. And so therefore, when we compare it with the suspension posaconazole, probably your tablet isavuconazole would be a better answer. We'll move on to the next question. Ankit, you are ready?
Yeah.
Okay, so this round I'm not going to go back. Take your time. Once we show the options, you have 30 seconds to answer. Right? Okay, this is the recommendation from the Lancet Infectious Disease article. Ankit, your question. This is a 22-year-old male, has no comorbidities, presents with high-grade fever and generalized myalgia for 3 days. He has a hemoglobin of 13, hematocrit of 44. He has leukopenia. He has thrombocytopenia. CRP is negative. Normal being more than less than 6. He has a little bit of transaminitis, AST more than ALT, and his Vidal turned out to be positive. Ankit, you have seen the question. Should I move to the options?
Just a minute.
Sure, take your time.
Okay.
Okay. So the patient has an ANC of less than 400. So the question is, what is the treatment for persistent fever and neutropenia? Your time starts now.
So the question is with respect to persistent fever and neutropenia or the primary condition?
Patient has persistent fever and neutropenia because of the primary condition.
So none of the above.
Absolutely correct. So what is the diagnosis here?
Would be a viral infection, means a KFD or something maybe.
This is very, very likely to be a viral infection, possibly dengue, or KFD is also a big possibility here. So the clues that are pointing towards dengue here is, one, there is a diffuse erythematous rash. There is a very high grade fever that started suddenly. You have raised hematocrit, you have leukopenia, and you have thrombocytopenia. The other thing that is helpful in identifying this is a viral illness is that CRP is low. So there might not be good correlation in all infectious diseases with CRP, but for acute febrile illnesses, there is enough evidence that viral illnesses, dengue, KFD, do not have increased CRP. So Vidal positive should not happen. One is that Vidal has poor sensitivity specificity issues. Second is, on day 3 of illness, Vidal should not be positive anyways. And so a lot of our patients come with Vidal positive. This is an outlier that we have to ignore. So here the question was that for dengue, if a lot of dengue patients have neutropenia, so do you treat or do you consider them as febrile neutropenia or not? So the answer is not. You don't do it. So there are a lot of evidence. This is one of the paper that showed that severe neutropenia in dengue patients does not require to be treated. We will move on to the next question. Manish. Manish, you are ready?
Yes, sir.
Okay. So this is an 80-year-old male patient with CKD5D. He initially presented with feature suggestive of Boraf syndrome. There was transhydral repair was done with mediastinal drain. Patient was put on total parenteral line, nutrition through central line, and post-operative day 4, he had a new onset fever. On Friday, a central and peripheral culture was sent. It flagged Candida, and after Malditov, they said it is Candida krusei. The central line was removed, and the patient improved after 4 days of empirical caspofungin. On Monday, as a part of routine ophthalmological evaluation in all patients with invasive candidiasis, the fundus was done, which showed endophthalmitis without vitritis. Manish, you have understood the question?
Just a second, sir.
Sure.
Yes, sir.
Okay, so we'll move on to the options. So what is the treatment of choice? We'll start the timer.
Change to fluconazole.
Okay, so fluconazole would have been a good option, but in this case, krusei has an intrinsic resistance to fluconazole. And it has been seen that almost all isolates of krusei that are resistant to fluconazole are sensitive to voriconazole. There is another reason why you should switch to voriconazole is that patient has endophthalmitis without vitritis. In that case, caclofungin is not the best option. So you have to either move to amphotericin B or you have to move to an azole. And because the duration of therapy for endophthalmitis without vitritis is 3 to 6 weeks or 4 to 6 weeks, you will have to give an oral therapy for a longer duration. So in this case, the choice was between flu, vori, and fossa, and the better answer would be change to voriconazole. So this is from a CMR article, and this is just the penetration of different antifungals. And if you see Candida krusei, you will see that it is resistant to fluconazole. Okay, so the next question is for Rahul. Rahul, you ready?
Yes, sir.
So this is the IDS recommendation for Candida chorioretinitis without vitritis. Okay, this is a 35-year-old male. In August, he presented 2 weeks after first rainfall in the region. He's a farmer, diabetic, and received steroids during COVID. Post-COVID, after some weeks, he presented with features of brainstem involvement. He had shock at presentation as well. Ultrasound reveals abscess in liver and spleen. CSF showed 250 cells, 95% lymphocytic. This is the MRI picture, and the patient improved in 11 days with empirical meropenem therapy. This is the stem of the question. Whenever you're ready, we'll move to options.
Yes, sir.
Okay, so your options are, what is the next step? Your time starts now.
Options. This is a case of maybe for Burkholderia pseudomallei, and we can change this to ceftazidime after 2 weeks of therapy of meropenem and continue for a total duration of 8 weeks.
Very good. So this is the right answer. This is Burkholderia pseudomallei. So the first thing that we have to know is that in the milioidosis, you have to treat for a total of neuromilioidosis, you have to treat for a total of 8 weeks duration. So the option was between continuing meropenem and continuing ceftazidime. So one is that with the principle of antimicrobial stewardship, you should de-escalate to an antibiotic with a narrower spectrum. The other thing is that there have been studies which have shown that patients on long-term meropenem therapy in Burkholderia pseudomallei, they develop resistance, whereas there is almost no resistance reported to ceftazidime, and therefore the answer in this case would be C. Okay, so we'll move on to the next question. Rohit, you ready? Sorry, Siddharth.
Yes.
Siddharth, ready?
Yes, sir.
Okay. This is a 50-year-old female with the following imaging and HPE findings. What is false for the treatment of choice? So I'll give you a little bit of time to see the images. Here the options are on the same slide.
Yes.
So I'll tell you when the time starts. Okay, so I'm starting the timer, Siddharth.
Yes, sir. The answer would be B, maybe, sir. Cannot be given in pregnant.
Okay, you have chosen which one? B, cannot be given in pregnant. Okay, so the question was, what is false? What is the diagnosis that you have made?
This looks like nocardia, sir.
Okay, so this is hydrated cyst, Siddharth. So in the first image, you will see a pulmonary hydrated. In the second image, you will see a lot of daughter cyst and liver hydrated. And in the HP, you will see laminar membrane in focus. This is a magnified image. Okay, so the treatment of choice for hydrated cyst is albendazole. So albendazole cannot be given in pregnant. It is said that you avoid giving albendazole in pregnant and try to give it post-pregnancy. There is no dose adjustment required for hepatic impairment. It can cause transaminitis, and it has good CNS penetration. That is one of the reasons why we give it for neurocystic sarcosis as well. The thing is that in general, when we give albendazole, we give for intestinal parasites where we don't want albendazole to be absorbed. And that is why in those cases, we give it an empty stomach. But when you have a systemic infection, you want albendazole to be absorbed. And therefore, at that point of time, you have to give it with fatty meal, right? So therefore, the answer is A. Okay. Rohit will move on to the next question. You're ready?
Yes, sir.
This is a question. 28-year-old female with bilateral leg swelling, no CNS involvement. Look at the image properly. Focus on the limbs. What is true for the treatment of choice of the adult form of the causative agent? So I will start the timer in another 5-10 seconds. Take your time. Look at the image. Try to find what is the anomaly here. We'll start the timer, Rohit.
Sir, fourth dosage modification in patient with CKD.
Okay, so what is the diagnosis here?
Sir, exactly. Just as
What is the diagnosis?
sir, was it absent kidney, I think, sir. Yeah.
No, so the diagnosis here, this diagnosis here is cysticercosis. You can see white calcified spots in the muscle. Okay, so for cysticercosis, the adult form is tinea solium, right? And the drug of choice for tinea solium adult form is praziquantel. So for praziquantel, now the thing is that one of the things that you have to monitor when you give praziquantel is whether there is development of any arrhythmias. Second is that it can be given in pregnant patients, unlike albendazole. Okay, there is no dosage modification that is required, and it has interactions with rifampicin. So the thing is that albendazole, when we usually advise albendazole, we say that you chew the tablet. But for pyrazinamide, the recommendation is that you should not chew it, and it should be swallowed. And therefore, that is the true thing.
Okay.
So the total,
Okay, at the end of second round, Dr. Ankit is at 16 points, Dr. Manish at 4, Dr. Rahul at 14, Siddharth at 10, and Rohit at 4. Okay, we'll move on to the next round.
Okay. In this round, so there are a series of 10 questions. So the idea is that you have to identify the antimicrobials. So the thing is that we'll give you 4 successive clues. There's a total of 1 minute. So the first clue itself is able to give you the answer, but the first clue is a little harder. As you move on to successive clues, it makes your job easy, but then it will reduce your marks as well. So if you answer on the first clue itself, you get 10 marks. But if you're not able to answer, if your answer is wrong, then the question ends for you there. If you don't want to answer at first clue, you'll ask for the second clue. So you will have to direct. There is 1 minute timer, right? We will be monitoring the timer. Prithvi will tell you that 45 seconds are up, 30 seconds are up. So the thing is that if you're not able to answer the first clue, the trick is that you tell next earlier, right? So all of the questions are about antibiotics. You have to identify the antimicrobial in all the cases. And all of the antibiotics are either available in India for routine clinical practice or for susceptibility testing. So all the fancy antibiotics you can exclude, right? There are no passings, and in round you will have 2 questions. Everybody understood, right?
Only one chance at answering.
Yeah. Everybody understood, right? So there is no guessworking here. If suppose you answer wrong, then your answer is, then we stop the question there itself, right? Ankit, you are ready?
Yeah.
Okay. So I'll just, before we go on to the questions, I'll just give an example of how things are, how we are going to move ahead in this round. Everybody can take a guess. This is just a dummy question. So you have to identify this elf from the Harry Potter universe. Okay. This is a male house elf who lived at 12 Grimmauld Place. Anybody?
Next.
So the thing is that there will be a timer. So if you don't know, it's better to say next, right? So I'll move on to next. Ankit, you play, try and see. Should I go next?
Next, yeah.
So this elf helped Lord Voldemort to place his Horcrux in the crystal cave.
30 seconds left.
Next.
Okay. He was loyal to Regulus Arcturus Black.
Next.
He's not Dobby.
No idea.
Yeah, anyway, so the idea is that the first clue was harder. The last clue is pretty easy. So the answer was creature. But anyways, we'll move on to the real question. Okay. So Ankit will start and your timer will start the moment we move on to the next slide, right? Okay. Okay. So identify the beta lactal. Okay, your timer starts.
Next. Next. Ampicillin.
Yeah, this is a wrong answer, but I'll give you a guess here again. You can take a guess again if you want, because there is a little bit of, overlap here.
Okay, means
Your time is up. If you want, you can take one more guess.
either amoxicillin or ampicillin.
Yeah, so the answer is amoxicillin. Okay, so we'll give you 5 marks for this. So amoxicillin, among the beta-lactam, amoxicillin is the one that causes crystalluria. It has good activity on Streptococcus and E. faecalis, but relatively poor activity on Staphylococcus. The reason why I gave you mark is that because both ampicillin and amoxicillin, the second point holds true, but not for point 1. And Listeria, the treatment of choice is ampicillin. Alternatively, you can use amoxicillin. In European countries where ampicillin is not available, they use amoxicillin. The fourth one would have been very easy, that it causes rash in patients with infectious mononucleosis, right? You can see the spectrum here, and you will find that amoxicillin has the addition of clavulinate to amoxicillin actually improves its activity against MSSA. So it in itself is not very good for MSSA, right? But it works for strep and enterococcus. So next question is for Manish. Manish, you ready?
Yes, sir.
Okay. So you have to identify the parental cephalosporin. Your time starts now.
Next. 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 Oxacillin.
No. So the answer here is cefoxitin. So if you see the first option, it shows it has activity against Bacteroides fragilis. So cephalosporins usually do not have good activity against anaerobic organisms, but cefoxitin has good activity against anaerobic organisms. Again, this is one of the differentiating features. ESBL, it is sensitive to ESBL but resistant to AMC, and it is actually a treatment for rapid grower anti-M, including M. abscessus. It can be used in the treatment regimen. Okay, and it is used as a surrogate for methylene synthesis. This is what we the disc diffusion. The current choice is use of cefoxitin, right? Okay. So these are the parental cephalosporins, and you will see that only cefoxitin has activity against Bacteroides fragilis. Okay, next is Rahul. Rahul, you ready? Rahul, you ready?
Unmute.
Yes, sir. Yes, sir. ठीक.
Time starts.
He's on phone.
No, he's talking. Rahul, are you ready? Okay.
So identify the parental beta lactam. So this time starts now.
Ceftazidime. Yeah.
Okay, so you lose this one. So anybody else, now this is open just for guess. There is no marks for guessing. Anybody else wants to guess at this point of time?
Cefepime.
Cefepime, very good, Siddharth. Who said that? Siddharth only, na?
Yes, sir. Yes.
Good. So the answer is cefepime. So basically, I'll show you the other clues also. Cefepime also has neurotoxicity. It has lesser activity against ESBL than AMC. And the fourth was easier one, that's a cephalosporin. You will see here cefepime and ceftazidime. You will see that both do not have anaerobic activity. He has an activity against Pseudomonas, but cefepime has activity against MSSA, but ceftazidime does not have activity against MSSA. We'll move on to the next question. Siddharth, identify this parental cephalosporin.
Yes, sir. Next. 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 Ceftazidime.
I'll give you one more guess. See the question properly and then answer. Okay, sorry,
Yes.
Siddharth, I'll not be able to give you the answer. So ceftazidime part is correct, but
Ceftazidime, avibactam.
avibactam.
Yes, sir. So,
Fine, we'll give you 3 marks for this. But try to complete your answer, because you see that simple things, we have already discussed some of the points before. This is a cephalosporin that acts against Pseudomonas but has no activity on MSSA, narrows it down to ceftazidime, but I have written it acts against ESBL and AMC as well. So that tells you that this is possibly ceftazidime avibactam. Again, the other clue is that it acts against KPC. This is something that we routinely do, and then empirical treatment, it's a very common practice to combine it with astanon, right? So these are the agents. So these are the ones. So because I said ESBL, AMC, we were looking at VLBLI inhibitors, and this was the answer. Okay, we'll move on to the next person. Rohit, are you ready?
Yes, sir.
We have to identify this parental beta lactam.
Next. Next. Next.
30 seconds.
Ertapenem.
Very good. So the answer is ertapenem. So in the first point, if you see ESBL, AMC, MSSA, anaerobes, if you give all these 4 things and there is a parental beta lactam, so your answer automatically becomes a carbapenem. And the thing that you needed to know is that ertapenem is the one that does not act on Yersinia. Other carbapenems will not act on KPC as well, but ertapenem does not act on Yersinia. Second thing is that both Mero and IMI will have activity on nocardia. IMI more than Mero. Some species, Mero probably would have better activity, but ertapenem does not have. And the other important thing why we do not prefer ertapenem in empiric therapies for nosocomial infection is it has no activity against Pseudomonas and Acinetobacter. So this would have narrowed down further The last was it is dosed once daily, and that is why it is recommended as a good enough de-escalation option for antimicrobial stewardship. So you get 3 marks, Rohit. Right? So we'll move on to the next question. Ankit, you ready?
Yeah.
Okay. So here you can see that ertapenem does not have any activity against Yersinia. Okay. So you have to identify this antibiotic. Your time starts now.
Next. 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 Tigecycline.
Sorry, Ankit, this is the wrong answer.
Okay.
So the answer here is daptomycin.
Oh,
Okay, I'll show you the spectrum. So the options were very limited. These are the ones that we routinely use and have MRSA activity. And the question was MRSA, pneumococcus, and enterococci, but not on viridans. So you see, for viridans, tigecycline has activity, but daptomycin does not have. So that's why tigecycline was not the option. And the other reasons were that, again, C. difficile, only vancomycin has, maybe a little bit teicoplanin, but others do not have. And daptomycin has issues with myositis, and therefore it cannot be co-administered with statins. And very classically, this daptomycin is not used for pneumonia because surfactant deactivates. But in infective endocarditis with septic embolization to lungs, you can use daptomycin. Right. Okay.
Dr. Ram, emergency.
Fine. Okay.
Next question is for Dr. Manish.
So next question is to Manish. Manish, you
Yes,
ready?
sir. Yes, sir.
So you have to identify this parenteral antibiotic.
Next. Next. Next.
Seconds more. Seconds more. Do you have an option?
Sorry.
Time up, Manish. One last guess if you want. Okay. We'll move on. So if you see, I've just listed the broad spectrum antibiotics. Wait, which one were we were at? Which question? 7th, no?
7th.
Yeah. So I've listed the broad spectrum antibiotics here, and you will see that amongst the first part was that it has activity against MDR, Enterobacteriaceae, Pseudomonas, and Acinetobacter. That itself narrows down your options a lot. And if you see, colistin does not have any activity on Serratia amongst the ones that have broad spectrum activity. The second thing is that colistin is very specific for gram-negative organism, has no activity on anaerobes. The second will help you further. Classically, Burkholderia cepacia will not respond to colistin. In fact, people who are on long-term colistin can have this BCC infection. That is a problem. And colistin can be given as nebulization. There is controversy with regards to whether it is helpful or not, but it can be given. Can just for sake of discussion, can anybody tell me which other antibiotic can be given as nebulization?
Tobramycin.
Yeah, so tobramycin can be given. Now, amikacin can also be given for MAC. Anyways, so this was the answer. The next question is for Siddharth.
Dr. Rahul had an emergency call, so he will not be joining us for the rest of the quiz. So we'll move on to Dr. Siddharth.
Yes.
Okay, Siddharth, you ready?
Yes, sir.
Okay, so identify this parental antibiotic. Your time starts now. This is activity against. It has activity against all these.
Next. Next. Next.
30 seconds more.
So the time is about to go. Yeah, take a guess.
Ceftaroline, sir. Ceftaroline.
No. So the answer here is tigecycline. Okay. So if you see that this is a very, very broad spectrum activity. Okay. MSSA, MRSA, pneumococcus, enterococcus, enterobacteriaceae, and acinetobacter. Okay. Second, it has good anaerobic activity. Like I said, like other than cefoxitin, ceftriaxone, but it's not available. No other cephalosporins have good anaerobic activity in isolation. Maybe in combination they can have. And it does not have any activity against Pseudomonas. Classically, tigecycline does not work for Pseudomonas. And the other thing is that since it's launched, there's a black box warning in patients with VAP. To overcome that, we give a higher dose of tigecycline, 200 mg loading and 100 mg BD for patients with VAP. We usually try to combine it, right? You can see the spectrum of activity here. If there was if there's a confusion, we can linger on it for a longer time. But I think we'll move on to the last question. Rohit.
Yes, sir.
You ready?
Yes, sir.
Okay. So identify this antibiotic. Your time starts now.
Next.
Streptococci. There's extra P.
Next, sir.
Thirty seconds more.
So Septron.
Huh?
Septron, sir.
Sorry, this is the wrong answer. It was close, but it's a wrong answer. Anybody else wants to take a guess? Okay. Yeah. What did you say?
I think so.
Yeah. So the thing is that when you see PCP, so your answer would be either Septran or clindamycin, or some of the other drugs that we commonly do not use. Primaquine can be one of those, right? Again, when you see toxoplasma, you can have clindamycin or Septran, right? But when you move on to actinomyces and strep anginosus, this is where your clindamycin will come. When you see the second question, clindamycin has good activity against gram-positive anaerobes, but is not really good for Bacteroides fragilis, right? There is a common dictum. Might not be always true, but there's a common dictum that above diaphragm use Clinda, below diaphragm use metronidazole, because of a little poorer activity against metronidazole. Then again, the third thing is just stressing on the fact that there is no activity against gram-negatives. And fourth would have made the job easier that it has antitoxin activity, right? Okay. So
Extra question.
we have one extra question because Rahul has to leave. So what we'll do is that the marks remain same. If you attempt, you get full marks. But if you're wrong, then you get same negative. Like for example, if you attempt at question option 1, you will get you're right plus 10. If you're wrong, you get minus 10. Second option plus 7 minus 7. Third option plus 5 minus 5. Fourth option plus 3 minus 3. Right? I will move at my own pace.
Reason.
Yeah. And what you can do is that you can just raise hand in your all your screens are visible, so you can just raise hand and then we'll ask you the question, right? Okay, and we'll not tell you the answer till 4 options are over, so that everybody gets a chance. Okay. No, we want to see the screen. Not raising hands.
He's doing the raise hand on.
Just raise the hand on the screen. Okay, no need to press the button. Just raise the hand. All of you are visible, right? So this is the last question. Identify this antibiotic. Okay, nobody is raising hand. Okay, nobody is raising hand. Okay. Last option makes it very easy. Anybody wants to try? Okay, Ankit. Try.
Trimethoprim-sulfamethoxazole.
Wait,
Amic
Ankit.
acid. Amic acid.
Siddharth?
Trimethoprim-sulfamethoxazole.
Yeah, so Ankit gets +3, Siddharth gets -3. So if you see that for NTM, amikacin is one of the therapy. In fact, for MAC, the only FDA approved therapy is actually liposomal nebulized amikacin. It also works for nocardia, but it has no activity against Brucella, Bartonella, and staph. Right? This is where Siddharth's answer goes wrong, is that Septran has activity against staph as well. The next question is that next thing is that it has no activity against strep, enterococci, and anaerobes. Then it's concentration dependent killing. We know that we try to dose it once a day because of its concentration dependent killing, and its only place probably where it can be used as monotherapy is for UTI. Okay.
Okay, so at the end of the first 3 rounds, Dr. Ankit is at 24, Dr. Siddharth at 10, Dr. Rohit at 7, and Dr. Manish at 4. So now we'll move on to our final round.
Okay. Fine. So the final round is the Kahoot round. This is where you can score maximum points. So what the thing is that there are 6 questions. You can score maximum of 60 points. Everybody gets to attempt, so everybody has an equal chance of winning here. So you all have downloaded the Kahoot app. We'll send you a WhatsApp on the group. You will get the number with which you can log in, right? And there will be 30 seconds each for the question, and faster you answer, more you score. So your score in Kahoot will be in thousands, but we will divide it by 100 and I'll add to the final score, right? Okay.
There's some doubt.
So will it matter if you're answering it fast, or we need to just answer within 30 seconds?
No. If you answer fast, you'll get more score. So the scoring will be done by the app itself. And so, you have to be right to get any marks. But I think the least you can score is 500. That means 5 marks for each question. And the maximum you can score is 10 marks. So you will have to ration it out according to, what you feel is the right option. So the questions are fairly easy here. So, and there are no negative marking. So attempt at least. Share the screen.
We've sent you the pin on the group.
It's also visible on the screen. We're waiting for 4 of you to join. Rohit, Manish have joined. Siddharth and Ankit. Ankit, we have joined. Siddharth, everybody has joined. We'll move on. Okay. So this is your final round. Okay. So the answer here is amphotericin B. So basically the 4 images that were there. So these 4 images, okay, it's not shared. Fine. So sure. Okay. So these were the 4 images that I shared. The first one is actually the bird's nest sign. In pulmonary mucormycosis, this is a bird's nest, just to re-emphasize that point. Third is a bird and shitting bird. So crypto and histo is a possibility. And fourth is a cave. And so bats and histo. So the connecting point here was amphotericin B. So one of you have got right. So the scores, oh, sorry, 3 of you have got it right. So this is the score. We'll move on to the next question.
Least preferred.
Okay. So basically, anybody has any idea what is the diagnosis here?
Could be sporotrichosis.
So no, this is actually conidiomycosis. So you see progressive nasal swelling, there is an ulcer, and here you see an aseptate hyphae which is surrounded by splendor hopli. These red things are eosinophils that have surrounded the aseptate hyphae. So the diagnosis here was conidiomycosis, and so you can give Septran as well for conidiomycosis, and almost all antifungals were. But echinocandins have not been evaluated. We don't know whether it works or not, but it has not been evaluated. So that would be the least preferred agent here. Okay. Okay. So I think everybody got, no. So Ankit got it right. So we'll move on to the,
I think Manish.
Manish also got it right. Good. So we'll move on to the next question. 68-year-old man with jaw osteomyelitis and ulceroproliferative lesion. What treatment will you avoid? Okay, so everybody has answered. Any idea what is the diagnosis here? This was cervicofacial actinomycosis. You could see yellow staining of the beard. That was because of the sulfur granules. And so basically the thing is that again, this is answered with the dictum itself that, above diaphragm anaerobic infections, you try to avoid metronidazole. But otherwise also there is a classification of drugs that can be helpful. Metronidazole is the least helpful drug here. So the answer here is metronidazole. And okay, good. Now Ankit and Manish are leading. We'll move on to the next question. 24-year-old HIV male patient with these lesions for 5 days, which therapy is least preferred? Okay, good. So, anybody, what's the diagnosis here?
Secondary syphilis.
So secondary syphilis is the diagnosis, and the treatment of choice is penicillin, but you can use amoxicillin or azithromycin as an alternative agent as well. Even doxy can be used, but levofloxacin is not an alternative agent that can be used for syphilis, right? Okay. Good. So we have, this was the third question, right?
Yes.
Next is the fourth question. Sorry, fifth question. There are structures in the picture, black to brown. That is what you have to focus on. Okay, everybody's answered already. So what is the diagnosis here?
Dimetitious fungi.
This is the dimetitious fungi. Most common is Cladophillophora bantiana. And so whatever evidence we have as of now, azoles and amphotericin B, possibly in combination, has to be used for the treatment. Caspofungin again is not an answer because of its poor CNS penetration as well. So even if you don't know what is the diagnosis, you can answer based on the properties of caspofungin. Okay. So, okay. So now everybody is neck to neck. We'll move on to the next last question. This is the last question of the day. So 43-year-old female, CA breast, 4 cycle of chemo, rapidly expanding skin lesion, preferred option for antimicrobial. This is on the thighs, lateral aspect. Okay, so this, what is the diagnosis here?
Ecthyma gangrenosum.
Ecthyma gangrenosum. Most common organism would be
Pseudomonas.
And most commonly with ecthyma gangrenosum, there is corresponding bacteremia. And therefore, empiric therapy for Pseudomonas has to be combination. You can later on de-escalate to single therapy when the susceptibility reports are available. Right? For a rapidly expanding ecthyma gangrenosum lesion, you have to give combination therapy. Right? So this is just for this round. We will calculate the final score and tell you. So Manish has done the best in this round.
21.
Sorry, third in this round. Second is Ankit and first is Siddharth.
So Siddharth got 25 points. Ankit got 24 points.
We'll make it 24.5.
Manish got 22 points. Ankit got 24 points. Manish got 22 points. Whatever. Rohit.
Should not go there. What would the score? Just 1 minute. So we'll tabulate the results and just get back to you in a couple of minutes. Can we stop this screen share?
Did some video.
Yeah.
Go back. Next one.
Next, you go next, you go next. Go next.
I think everybody's should come.
You can get it.
Okay.
Yes.
It was 136.
But 14 we have to do. I'll just do it. We'll write it then after writing. You want to write each round or we'll just write one number? First, Anish is third. last year. 14th is 21.
Oh, this year combined total.
Total.
Fine, fine. 35, 26. Good, fine. Good enough. Okay. Minimize this.
Yeah, I think you were putting the ball, right? Total डाल दो जल्दी से 6
6.
10
And the order is not same.
Yeah. Oh sir, no, I'm beginning with this.
Acha, okay. 6.
10 8 24.5 24.5 final is 48. So that 0 Okay, the final scores are as followings. In fourth place, we have
Not sure.
we have Dr. Rohit Gupta with 21 points. In third place, we have Dr. Manish Kumar with 26 points. Our second prize winner is Dr. Siddharth Sadnani with 35 points. And our first prize winner is Dr. Ankit Mittal with 48.5 points. Congratulations to all four of you for performing so well.
Thank you.
Thank you.
Okay, so
We
we'll
hope you guys enjoyed the quiz as much as we did.
yeah, we'll get in contact with the winners.
Thank you, sir.
Thank you.
We have a small closing remarks, so please don't go anywhere.
So the first prize will have a cash award of 5,000 and the second prize will have a cash award of 3,000 and both will have carry a certificate. I congratulate all the participants. It was a very good quiz organized by Dr. Nitin Gupta and Dr. Prithvi. I should congratulate both of them and all the participants. You have done really well. And it was a very good competition. And I hope you have learned a lot. It was very educational because of the constant explanation and the slides which were done very well. Thank you, both the organizers and the participants. Moving on, we had other competitions which were held, especially by Department of Pharmacy Practice, led by the students of Pharmacy Literacy Club and guided by Dr. Sonal Shekhar. So I would like to announce the results of the competitions. There were slogan writing competition, debate competition, and patient counseling skit. So the prize winners for the slogan writing. The first prize winner is Suhita, PharmD intern of Manipal College of Pharmaceutical Sciences, and the runner-up is Mr. Parth Gandhi, is PharmD intern from MCOPS. Congratulations. The slogan writing was on antibiotic stewardship. Moving on to the debate, the topic was, has the surging dependence on antibiotics in the clinical setting eventually led to its own downfall in the future or in the near future? So the winner of the competition is Mr. Swapnil Raj, PharmD intern, MCOPS, and Ms. Fatima Zara, PharmD intern. Runners up, Ms. Lavanya Swaminathan, PharmD intern, and Ms. Anagha Ramamurthy, PharmD 5th year, both of Manipal College of Pharmaceutical Sciences. Congratulations to the winners of the debate. There was a patient counseling skit competition. The winners are Ms. Meera M, PharmD intern, and Ms. Lavanya Swaminathan, PharmD intern. Runners up, Ms. Suhita, PharmD intern, and Mr. Parth Gandhi, PharmD intern from MCOPS. Congratulations. There will be a physical prize distribution function in Manipal College of Pharmaceutical Sciences. With this, we come to the end of a 5-day long conference on combating antimicrobial resistance. I would like to express my gratitude to our partners. They are Kasturba Medical College, Mangalore, Department of Medicine and Department of Microbiology. From Kasturba Medical College, Manipal, Department of Emergency Medicine. And Manipal College of Pharmaceutical Sciences, Department of Pharmacy Practice. And also I would like to thank our international partner, Division of Infectious Diseases, Wayne State University, USA. We have had very educational 5-day conference with different themes on different days. And I hope it inspired and motivated everyone to have a relook at your practices of antimicrobial use. And this conference, which is observed during World Antimicrobial Awareness Week, could meet its objectives. Also, I would like to announce Kasturba Medical College, Manipal is joining WHO campaign of Going Blue for raising awareness against antimicrobial resistance. The entire building of KIMC Manipal will be lit up in blue tonight. And I would like to invite people to join us in the evening. And you can also shoot your photos in the photo booth, and you can upload it in your social media and raise awareness, and you can explain why you are going blue for AMR. Thank you very much. And I would like to thank all the participants and the audience. There have been many people who have joined us online and also who have been viewing our YouTube channels. Thank you very much. I request all the panelists, the participants of the quiz to switch on the video. We can have a photo shoot. Thank you.